So in the first presentation, we focused more on externalizing behavior disorders and identifying those. But given that there is such an over-identification of students with externalizing behavior disorders, I wanted to spend a little more time talking about internalizing behavior disorders. Internalizing behavior disorders go under-identified in schools, and that schools are less likely to identify students that are exhibiting external behavior disorder symptoms. And and so that's particularly a challenge, and something that I think we and all professionals that work in schools really need to look at is how can we make sure that we identify students that are suffering and yet are not very vocal or demanding our attention um, in order to receive services. This presentation I worked with my sister, who happens to be a social worker and works in the emergency department at Peace Health. So oftentimes, unfortunately, because students go unidentified in schools, it's only until they've acted out in either suicide or suicidal behavior oftentimes that we're able to get services for students that are, again, clearly suffering in our schools. So as we talked about in the previous presentation, our society seems fascinated with emotional behavior disorders, particularly in children, and trying to figure out where the cause or what the environmental factors are that really brings about behaviors that we see as pathological or problematic, and why is it that some students seem to exhibit those behaviors and not others. And I think some of the reason for this fascination is because, for many adults, when you see a kid who's exhibiting behaviors that are really outside of the norm of what other kids, in um, their typical development, if they're exhibiting behaviors that are so outside of that of their peers, we really want there to be some sort of external factor. That we don't want it to be just that, we want it to be that there's something wrong. We're a very uh, kind of medically minded society, and we really look at all behaviors as being some sort of kind of dysfunction, and so I think there's a fascination of trying to find out, what what are these causes, and assuming that kids are necessarily kind of born bad or are born with these problems. I think part of that is because it alleviates our responsibility as adults to understand that, what is our role in the context of students' lives, and because if it's something biological or if the kid comes hardwired with particular behavior problems, that really alleviates our burden then as teachers and other adults in children's lives, to have some responsibility for some of the behaviors that we see. So if we understand that probably behavior in general, most behaviors are pretty normal and pretty typical, and that it really we have to teach students, we have to teach children what behaviors are appropriate in what settings. It does put some responsibility on us as educators, versus just when we see behaviors that are um, that appear really inappropriate. It's again, there's that real desire to just kind of blame the child or blame it um, on something internal, rather than that people are growing up, and people are learning, and so we're the behaviors that we learn are really a collection of all of our experiences, and that there doesn't have to be a pathology when we see that people engage in behaviors that we really need to teach them are inappropriate. When we're looking at issues of mental health, I think it's important for us to realize that um, really, mental health is a long continuum. It's not like some people are are um, are always well, and some people are always have mental health issues, and that for most people it's very, very fluid. And so if we can think of it as more of a us problem versus a us versus them problem, I find that helpful for me in in working with and trying to understand students with behavior problems. So I do like this quote. So Stephen Hayes is a psychologist, and he talks about how most human beings struggle even in the midst of what appear to be very successful lives. And if you think about the relationships that we have, that you may you may be able to think of someone that you know where you say, oh my gosh, that person really seems to have it all. Their life seems perfect and they don't have any problems. I would really like to see their life. Typically with those folks, though, we don't know them really, really well, and that the more that we know people, the more that we realize that everybody struggles, even in what appears to be a very good, a very kind of happy, a happy life. And why this comes about is probably genetic and probably has occurred over um, as we've developed as a species on this earth. It tends to be the worriers that have probably been able to pass on their genetic material into other um, to the next generation. So imagine the um, you know uh, early humans, the ones that were more carefree, the ones that took more risks, they were probably the ones eaten by the saber-toothed tiger, and the ones that were more worrying, the ones that were more cautious, those are probably the ones that survived. And so some of this may have uh, a more biological or uh, component to it. So in some ways, we've really been programmed to worry and to worry about things that probably aren't going to happen, and that it's those kind of anticipatory concerns probably is what kind of kept us going as a species. Some interesting data that we have is that we know that 30% of all adults have a major psychiatric disorder at any given period of time. So that doesn't mean that they're diagnosed, but there are folks that are having symptoms to the point where they probably could be diagnosed. Half of all folks in Western society have a major psychiatric disorder at some point in their lifetime. And of that 50%, 80% are going to have one or more serious psychological problem. So of the half of the population that that is really suffering, that has a diagnosable mental health related issue at a period of time, 80% of those are going to have it's going to be reoccurring. So it's not going to be just one time. It's going to crop up at different times in our lives. So when we look at why students with externalizing behavior disorders are more likely to be identified, one of the reasons is that they're the ones that are trying to get the most attention. So if you look at these three pictures of kids, who are teachers going to pay attention to first? Their first attention is probably going to be with the kid who's acting out. And then what we find is that teachers also spend more time with students that are very successful, students that volunteer, students that do well. We find that teachers actually spend a great deal of time with those successful students. And so it's no surprise that the students that we tend to overlook are the ones that are oftentimes trying to become invisible in a classroom. So students with more internalized behavior problems, students that don't want attention, don't want unnecessary attention, those are the ones that we're going to miss. And so that's probably why we see the possibility of overrepresentation for externalizing behavior disorders, and why we're so likely to miss students who are suffering just as much as students that are more externalizing in their attributes of their behavior problem. But again, we miss the ones that just don't want to be seen. So some of the most common internalizing behavior disorders that we see in adolescents involve mood disorders, which involve, which could be depression or bipolar disorder. We see an increased likelihood of diagnosis in anxiety disorders, OCD, or social phobia. We also see a number of students that exhibit substance abuse, which we do identify now as a mental health disorder, as well as eating disorders. One of the challenges with mental health related disorders is that there's a kind of a cultural bias against mental health related issues in particularly in our country, but really it's a Western problem. So when people have other types of health problems, we see that oftentimes people provide unnecessary stigma towards mental health related issues. So if we think of mental health as we do with any other health disorder or health problem, we do see that that people respond to it or treat it very differently. the question comes in is that, why do we treat someone who's had a heart attack different than someone who may be dealing with a bout of depression? Why is it that we seem to value some health-related issues and provide more credence or more support for individuals with one health problem, and we dismiss others? And some of it are, again, these kind of I think are just challenges and that we have kind of as a society. So when we look at mental health disorders, the challenge is that most often you can't. It's not something that you can see. Unlike so you can't just kind of like pop open the hood of the car and like take a look and really point out what the problem is. With certainly with a lot of orthopedic problems, if you break your leg, you can go to the emergency room, you can get an X-ray or an MRI or a CAT scan or whatever that shows where the problem is, and so it becomes very clear and very evident for everyone. For mental health, it doesn't work that way. You can't just with most mental health disorders, there's no overt signs. There's no way for us to be able to get a good look and to be able to see on some sort of diagnostic imaging that someone indeed has a particular problem. The other problem with so using observation for mental health disorders is also challenging because there are problems with cultural sensitivity. There are certain behaviors that are more culturally appropriate that if we're not sensitive to the cultural differences and cultural experiences of different people, that we may over or underdiagnose specific problems. There's problems with standardization. You can have a couple different mental health practitioners that may give different diagnoses for different mental health related issues. And there's a heavy reliance on self-reported measures, in that so often with mental health, we're relying on the verbal reports of the person who's experiencing the problem, and that can be problematic, and that sometimes folks who are having any that relying or being when you're stuck relying strictly on people's self-reports of their behavior, it may not be as accurate. How can we assess what one person says they're experiencing when that may be how they express that may be very different than how another person would express the same thoughts or the same feelings? And so those are all kind of challenges. Also, age is an issue, and that when we're very nervous about providing mental health diagnoses, or at least historically we have been with children, because some of these things are some of the questions around mental health are developmental. Is this really a mental health related issue, or is this just a development problem that we all have develop different skills at different times developmentally? So working with folks with mental health disorders, it's not like being a mechanic. It's not like you can just pop open the hood, see what the problem is, get a new part, and put it in there and close the hood and send them on their way. That it's much more veiled. It's harder to see. It's harder to diagnose, and oftentimes treatment isn't very quick. So I've taken here the diagnostic criteria for depression that's in the Diagnostic Statistical Manual of Mental Disorders. So I want you to take a minute or two and kind of look at what the criteria is for a diagnosis. It's on this page and it's on the next one as well. So take a minute and kind of look at it and hit pause until you get a chance to read it, and then we'll talk about, or I'll talk about some of the challenges with this. So take a look at this slide as well. This is the rest of the criteria. Some of the challenges that we have in mental health and looking at diagnoses is that kind of to the layperson, as you read these, it's very easy to assume that everybody has or experiences these kind of characteristics. I think that's especially true in an area such as depression. So we all have times where we may have a depressed mood, but that doesn't mean that necessarily that everyone qualifies as having met the criteria for depression. Some of the things that we have to consider when looking at mental health diagnoses is how long has this been going on? Is it a appropriate response to environmental stressors? So you can see specifically in this criteria that we can't diagnose someone with depression if it's associated with bereavement. If someone has just died who's very close to someone, you can't, because they're sad because someone died, isn't that's appropriate mourning. That's not depression. So when we're looking at depressive disorder, we're looking at something that's outside of the normal reaction given the environmental factors. We also see this too when people are exhibiting problems at home, problems at school, financial problems, that sometimes being not feeling well, not feeling your best, having some depressive symptoms are very appropriate responses given what's going on in the environment. And we can't view what are appropriate responses and kind of lump that in with depression. That doesn't mean that there's not medications that can help with people in the short term when their context or their environment is such that it's causing great anxiety for people. But we have to try to keep that separate from what are mental health related disorders. So just because someone's sad or just because someone's feeling bad doesn't mean that they have a mental health disorder. It could just be an appropriate response, given the environment, given what's going on in their lives at this period of time. So I wanted to provide you an example of what a mental health diagnosis actually looks like. Hopefully, you won't see a mental health diagnosis listed in a cumulative folder. It's really not appropriate for schools to be maintaining and holding these types of records. But unfortunately, it's really not uncommon for parents after a child has been perhaps hospitalized for suicidal thoughts in order to come back to school and to bring in the discharge paperwork from the hospital. And oftentimes you'll see in there then an actual diagnosis sheet, this DSM kind of diagnosis sheet. So although those kind of records really are inappropriate for a school to maintain, just like we wouldn't want a whole bunch of other, just like we don't want other types of medical records to be put into academic files for schools. I thought it was helpful to at least be able to kind of see what these mental health diagnoses actually look like. So usually, well, not usually, they're always kind of divided up into 5 axes. So the first axis, both the first and second axis, there are certain mental health disorders that are either identified as axis 1 or axis 2. And for some of us, it seems a little arbitrary as to which ones are in those 2 categories. I think historically, we've kind of thought about axis 1 diagnoses as things that can kind of come and go, that are a little more transient in nature, and axis 2 diagnoses being a little more permanent or persistent. But when you actually look at the classifications and what disorders fall into those axis 1 and axis 2 classifications, that doesn't make as much sense. So it's hard to make practical sense as to why we have those divided up the way that we do now when we look at the actual classifications that are identified as such. Axis 3 are health-related issues. So if the student has health or medical-related issues that contribute or may increase the risk of mental health disorders, those are listed then into axis 3. And then axis 4, sometimes called the social worker axis, it looks at what is the context or what is the environment for which the student is living in. So and what this really helps with axis 4 is looking at treatment options. So there's a huge difference between someone who may, like in this case, have a major depressive disorder, and they've got asthma, but in this case, the person has limited social supports and no health insurance. So to be able to come up with a treatment plan for this person, that person's treatment plan and that person's chances of coming up with kind of a workable plan is going to look very different than someone who may have very close relationships with family members and have all the insurance and have a great health plan. So because again, the options that we have when we look at community-based services is very different based on those kind of contexts. So whether or not someone has a stable living situation, whether or not somebody's in a relationship where they live at home, all of those things can sometimes be listed there under axis 4 because it gives information to the clinicians in trying to help and look for services and supports for folks that are in the community. The final score that you see is Axis 5, which is undergoing a little bit of transition right now. It used to be referred to as the Global Assessment and Functioning Scale, and it's on a scale from 0 to 100. We're currently transitioning to a new scoring sheet, or new scores that are based on the World Health Organization's list. But currently, you still see global assessment and functioning scores coming out of hospitals. So I wanted to talk a little bit about those, even though eventually those scores will be replaced with what's called the WHODOS, or the World Health Organization Diagnostic Scale. So as I mentioned, GAP scores are based on a scale from 0 to 100. And I went ahead and just pulled some descriptors for each, for scores that fall into scales of 10, just so that you can get a general idea of what the purpose of this number is. So the kind of the goal of the number is to give clinicians a clear goal of where this person is at this particular moment in time. People may have different mental health conditions, and yet how they're functioning in the world is very important for being able to determine what kind of services people need, or how much supports or kind of services need to be provided. So for people that have a GAP score at one period of time, when they're diagnosed, if their GAP score is between 90 and 100, these are folks that have absolutely no symptoms of a mental health related disorder. So we look at those folks as having kind of superior functioning in a wide range of activities. Life problems never seem to get out of hand, is sought out by others because of his or her many positive attributes and qualities. So for folks that score in the 90 to 100, these are folks that we really think of as folks that are just doing very, very, very well. These are and when I look at my own life, there's a lot of times that I'm certainly not functioning in the 90 to 100 range. And so it's not like a score on a quiz or something like that, where you're expecting, 90 to 100 in someone's life at every moment. In that, these are folks that are just really excited to be alive. They're doing great, and other people really search them out to spend time with them because of how well adapted they are to a particular environment. For folks that score in the 80 to 90 range, what we see is that these individuals are absent or have minimal symptoms. Now, some examples of minimal symptoms might be mild anxiety before an exam. Now, let's take a minute and just talk about that. So if minimal symptoms are mild anxiety before an exam, I don't know if I've ever then really scored much in that 90 to 100 range, because when we look at a mild anxiety before an exam, I would say that's more typical of very highly functioning people. So again, 80 to 90 is still a great score. We see good functioning in all areas for folks within 80 to 90. Interested and involved in a wide range of activities, socially effective, generally satisfied with life, no more than everyday problems or concerns. So I think for most of us, even folks that are functioning really, really well, scoring within that 80 to 90 range is very typical. Now, as we go down on the scale, it gets a little more, we start to see more impairment. So for folks with the 70 to 80, GAP scores in the 70 to 80 range, we see that if symptoms are present, they're often transient and expected reactions to psychosocial structures. So difficulty concentrating after family arguments, that's really typical. No more than slight impairments in social, occupational, or school-based functioning. So temporary falling behind in schoolwork may be an indicator of someone who's scoring in the 70 to 80 range. So again, most of us, even when we're doing really, really well, the 70 to 80 is very typical for for a healthy person kind of functioning in the world. For folks scoring in the 60 to 70 range, we see that there are some mild symptoms. So a person may exhibit some depressed mood or mild insomnia. Now notice it's mild insomnia. So a lot of us, that's just that may be just typical functioning for us. Or they may have some difficulty in social, occupational, or school-based functioning, such as occasional truancy. Could be theft with inside the home. But generally functioning pretty well and has some meaningful interpersonal relationships with others. So again, pretty typical functioning, especially for folks growing up. For people in the 50 to 60 range, we see moderate symptoms. So they may have a flat affect or circumstantial speech, occasional panic attacks, we would look at as moderate symptoms, or moderate difficulties in social, occupational, or school-based functioning. They may have fewer friends, they may have some conflicts with peers or coworkers. So as we move down to the 40 to 50 range, we start seeing reality testing being more of a problem for folks that are, and clearly impairment that we're starting to see uh, in the lower half of the GAF scores. So for 40 to 50, we see serious symptoms. So some examples might be suicidal ideations, severe obsessive rituals, frequent shoplifting, or any kind of serious impairment in social, occupational, or school-based functioning. So may not have a lot of friends, unable to go to work, or having problems with work. For 30 to 40, we see some impairment in reality testing or communication. So reality testing is if you have somebody who's, if you have two people that experience the same thing and one person experiences was vastly different than another person who observed exactly the same thing, we look at that as a little bit of reality testing. How accurate is this person as a historian in events that they've experienced or about events that have happened in the past? So that's what we're really looking at with kind of reality testing. Does this, does this make sense? Was their experience typical, a typical experience for people who've experienced the same, the same behaviors? So speech at times may be illogical or irrelevant. There may be major impairments in several areas such as work or school, family relations, judgment, thinking or mood. Depressed adults often avoid friends, neglect family, or have difficulties with working. Children frequently may engage in aggression with other kids, um, be deviant at home, and failing at school. So for the range of 20 to 30, we see behavior is considerably influenced by delusions or hallucinations. So again, this is kind of, continuing to have problems with reality testing, and experiences are really outside the norm of what most people experience in the world. And that there's these severe impairments to communication and judgment. And then with 11 to 20, we're looking at person has some danger of hurting themselves or others. So suicidal attempts without clear expectations of death, frequent violence, manic excitement, or occasionally falls in, only engages in kind of minimal personal hygiene or gross impairments in communication. And then 1 to 10 is this person is persistently endangering or hurting themselves or others. A 0 is considered not enough information, so nobody gets a 0 on the GAF score. So again, the purpose of this is you're not going to be diagnosing folks or placing folks in a GAF, giving folks a GAF score, but I think it's somewhat helpful for you as teachers to have a general understanding about what those scores actually mean. And so when we're talking about people that are impaired, those lower scores are folks that are really suffering, that are really impaired in kind of that daily functioning, and then also just allows for some differentiation between people that are doing okay. There is a difference between people that are doing okay and people that are just doing amazingly at a particular moment in their life. And so the GAF range allows for kind of placing folks on this continuum of functioning. So with the new edition of the Diagnostic Statistical Manual of Mental Disorders, the new edition, which is called 5, they are moving away from using the GAF scores, and there's a move to a new system called HUDAS. And basically it's an international scale rather than the DSM was kind of more a Western Europe, North American scale. So it basically looks at those same qualities that we typically see in that range, in those kind of same ranges for the global assessment and functioning, but it's actually a different assessment method, and it really is looking more at how disabled someone is in a particular environment. So when we look at functioning levels for people with mental health related disorders, and we look at kind of this global assessment of functioning or HUDA scores, you'll see that the more severely impaired an individual is, it oftentimes talks about that person's ability or that person's safety when we look at safety as to whether they're going to hurt themselves or whether they're going to hurt others. So in looking at folks with severe mental health related issues, one of the aspects that we really look to see to measure severity is that um, context of um, self-harm. And when we look at this kind of contextualizing harm across the spectrum, we see there are some behaviors that people engage in that are less concerning, and then and yet still a problem. And then how those aspects of self-harm increase to more and more dangerous behaviors. So the first level of self-harm, when we look at kind of the how self-harm increases over time, we see that oftentimes the people will engage in fleeting thoughts as kind of the first step that we think of as self-harm. And what fleeting thoughts are is just kind of what it says. It's people are having these kind of brief moments of thought about their own death, or what would happen if um, uh, if something happened um, immediately that would that someone could actively engage in ending their own life. So we see this if people are, let's say, standing on a bridge and looking over the bridge, and then start having these thoughts about what would it be like to just fall over the top of the bridge, or someone is swimming in a pool and then starts to wonder, well, what would it be like if I just quit swimming um, and and um, and started to drown. And what we find is that a lot of people who are having these kind of fleeting thoughts, they're very short and very quick. Where people are already having a very difficult time, they're suffering, and people will have these thoughts of um, of what it would be like if life just kind of ended or terminated at this particular moment. And so when they're short in duration, and the mind kicks in and then kind of questions some of those thoughts that we have, we oftentimes think of that as kind of fleeting, as what we think of fleeting thoughts. They kind of come and go, they're transient, but they're short-lived, and usually we are kind of shocked that we had that thought a little bit later, and start to kind of question our own why we had that thought at that particular period of time. So that's at the very start of the self-harm spectrum. The next step is ideation, and what ideation is when people really um, uh, kind of question if their life ended, they make that situation seem much grander, or spend a lot of time perseverating on their own death. So in ideation, you may see people who are really planning out the details of their own funeral, wondering who's going to be sad that they're gone, kind of wondering what that's all like, um, or somehow kind of rationalizing that if they died, it wouldn't be that big of a deal, or it would be better for other people in their lives. So for those of us as teachers, we intervene in these first two steps. When you start hearing students engaging in these kind of behaviors, although they're very common, we all have, I think most people have had fleeting thoughts and ideations at times in their life. But as teachers, we're not trained to be able to differentiate some of these categories across the spectrum. And so it's important for us to recruit assistance from professionals during these first stages. And that can be something very simple as, um, talking to the school counselor, encouraging a student who's, disclosing with you um, um, thoughts of ideation or fleeting thoughts, to have a conversation with a counselor, with a school counselor or a school psychologist to just kind of talk through some of those thoughts and feelings. And we can usually do that in such a way of just really framing it in a matter with students that we really do care about their best interests, and that whenever we as adults have problems, it's good to sometimes talk that through with other people. And so with those first steps, we do really want to reach out and get assistance from the resources that we have at school. The next step is risky behavior. And again, some of these, even though these are across the spectrum, it doesn't mean that every person will have every single one of these characteristics or engagements in these behaviors when they're suicidal. but these are some risk factors to kind of look out for. So some people will engage in risky behavior, and what that is they'll engage in behaviors that put their lives at risk. And if the person is doing that as a way of kind of flirting with a suicide attempt, we think of that as risky behavior. So maybe driving in a car and closing their eyes and thinking, that it wouldn't be that bad if this car went off the road and they were killed. Or people who will sometimes engage in binge drinking, and then purposely getting behind a car with the idea that if something happened, it wouldn't be so serious if that person died. So those are some examples of risky behavior. Risky behavior is sometimes hard to identify because in some cases folks are doing things out of kind of peer pressure, and it's really not out of a desire to on the spectrum of self-harm. It's more doing it for to impress their peers. But that's why we need professionals to really look and to differentiate. Is this on the spectrum of self-harm, or is this not? Is this some other behavior? And so that's why we have to have professionals to kind of assist us with these steps along the way. Now the next one is planning, rehearsal, and means. Now for hospital staff, when someone comes into an emergency department, this is the area of self-harm that they're really trying to adequately assess to determine whether or not someone needs to perhaps be held over in an inpatient setting, or whether or not they can be discharged and receive psychiatric services through outpatient. For planning, rehearsal, and means, whoever is doing the assessment will have the person kind of describe what they've done as far as practicing of the suicidal behavior, if that's occurred. What is their plan? How do they plan on killing themselves? And also assessing whether or not the person has the means in order to complete suicide at that time. And so it's those three aspects that are really being evaluated to figure out, is this person able to be handled through outpatient care, or is this person in immediate danger and needs to be held inpatient at that period of time. So another step that we see is self-harm. So there are folks that will actually injure themselves as a means of and actually these next three are all pretty similar. So when we're looking at some aspects of self-harm where someone is hurting themselves as a way to distract from feelings of anger or sadness, and they're doing it as and distracting themselves from those feelings of suicidality that they're experiencing. The next step is suicidal gestures. We'll see sometimes where people will engage in some suicidal behavior that's not at high risk, where people may be engaging in behaviors that are not likely to end their lives, but we think of those as suicidal gestures. So they're engaging in practice, but the method that they've chosen isn't necessarily lethal. And so a therapist is going to be, or whoever's doing the clinical assessment is going to be looking to see how dangerous is this behavior that they're engaging in, that they view themselves as being suicidal. And the final step on this, or the second to final step on the spectrum, is suicidal attempts. And what these are attempts for behaviors that, if it had been completed, would terminate life. So this is why we have professionals that are doing these assessments in hospitals and other mental health facilities, because in doing this assessment, you never want to make the individual who's suffering feel like they're not that their plan isn't effective, or that they don't need help, or they don't need care. And so it's very important that people are skilled that are doing these assessments, so that again, we can get people the help that they need, but not interfere necessarily with their their constitutional rights to freedom of movement. So we can't just lock people up just because, without very good reason that they're endangering themselves or others. And then, of course, the final step in self-harm is completed suicide. Again, though, as teachers, we want to intervene early on. So with fleeting thoughts and ideations, that's where we reach out for help with others. Usually when we get into risky behavior, plannings, rehearsal, and means, we oftentimes reach out to emergency departments to help with that assessment at that time. And so that may be sending the student to an emergency room. And then once someone is at the hospital then has to make the determination about is this um, are these symptoms so acute that the person has to be seen inpatient, or can this person receive services in outpatient mental health setting? So self-harm goes by a lot of different names. We sometimes hear about it as self-injury or self-inflicted violence, self-injurious behavior, self-mutilation. And it's defined as deliberately or intentionally injuring one's own body that causes tissue damage or leaves marks for more than a few minutes. And this is important. So it leaves marks, and it's done as a way to cope with overwhelming or distressing situations. So we see that self-harm is highly correlated with mood disorders, anxiety disorders, and eating disorders. Uh, so it's important to realize that there's a lot of that it's not just the behavior, it's not just the act of inflicting um, injury to oneself, but it has to do with what's the context. Why is the person engaging in that behavior, and so is this really a situation where the person is using this behavior to take away those feelings of shame and guilt and frustration and anger that they may be experiencing. So again, the very same behaviors for one person may be self-harm, and the other one it may be just an individual um, uh, and for another person it may not be. So we can see this certainly with piercings or branding or even tattoos in some ways, that we see that some people use the pain that they feel as a way of escape, as a way of dealing with those overwhelming and stressful situations. For those folks, we need to we need to be more concerned about those types of behaviors as folks who may engage in branding or piercing or breaking of bones as a way of gaining social attention from others, or just because they like it, because it's um, for aesthetic reasons. So a good example of self-harm, my sister had a couple adolescents who she had go in and that she was evaluating in the emergency department. And for a couple of the students, what they'd been doing was actually breaking each other's fingers. They'd been um, uh, they've been pulling each other's fingers back until there was injury, and they were, trying to assess who said to stop first. So of these three kids, one of them was really engaging in that behavior in a form of self-harm, and that he was using that pain as a way to distract himself from the feelings, the distressing feelings that he was having about his life, his overwhelming feelings. But for the other two students, it was really just a kind of a peer pressure kind of thing, that they didn't really know why they were doing it. It wasn't that they were it was more of a way of kind of showing off in front of their friends. So you can see how the same behavior can, for some people, be an aspect of self-harm, but for others can be just kind of an inappropriate uh, social interaction with peers. The prevalence of self-harm, we know that about 2 million people in the US engage in self-injurious behavior. About 1% of the population has inflicted physical injury upon themselves as some way to deal with cope with an overwhelming situation or feeling. Those numbers are likely an underestimation because the majority of acts of self-injury go unreported. The most common types of self-injurious behaviors include cutting, so involves making cuts or scratches on the body with a sharp object, including knives, needles, razors, blades, or even fingernails. We see that cutting is, we'll talk about on another slide as well. It has kind of an interesting history, and most of these aspects of self-injury go back to We see it in see incidents of self-injury that go quite far back into our history. We see branding, where persons will self-administer a hot object or friction burn on their skin that causes damage as a way of dealing with overwhelming feelings. We also see that picking at the skin or reopening a wound. Your word of the day is dermatillomania, which is folks who pull out or pick at their own skin. It's true that the urge to pick one's own skin often to the extent that damage is caused, which relieves stress or is gratifying. Some other types of self-injury that we see are trichotillomania is another one where folks will, as a way to relieve stress, will pull out their own hair. So that's dermatillomania and trichotillomania are that's what those two words mean. So hitting, we see sometimes people will hit themselves with a hammer or other objects, bone breaking, punching, head banging. We often see like head injury with those types of behaviors more often with autism or other severe intellectual disabilities. A few self-harm facts. Cutting has been usually seen as a solitary act, but it's been increasingly seen as a group activity. There actually is a fair amount of historical evidence around cutting going back several hundred years, and signs of that as a form of self-injury. Currently, it became more common and more talked about in the 80s, I believe, with Princess Diana, the from England, Princess Diana Windsor. She was very outspoken about her individual fight that she had with engaging in cutting behaviors on herself. At the time, it was really quite remarkable because it wasn't something that people usually talked about kind of openly, but she kind of removed some of the stigma of people who engage in cutting at that time. We see that group cutting is becoming more common, particularly with young girls, or it seems to be reinforced kind of socially, where groups of girls will get together and engage in some cutting behavior. So again, just like with other forms of self-harm, for some folks this would serve as a form of self-harm. For others it could be peer initiated, so a kind of a form of peer pressure that may not have to do with overwhelming feelings. There's no correlation has been found with socioeconomic status, so we see cutting behaviors across all ends of the socioeconomic spectrum. And a history of self-injury is not a predictor of future suicide. So self-injury in itself isn't necessarily a concern for suicidality, but it does need assessment, and to have someone who's who can assess and provide treatment for folks and monitor that behavior to make sure that it isn't, it doesn't become life-threatening. And again, it impacts people of all ages and ethnic groups. When we look at the occurrence of suicide in the United States, we know that we're looking at about 30,000 suicides per year in the United States. It's the third leading cause of death for youth. And rates of completed suicide, it's very low for students 15 to 19 years of age. For pre-adolescent suicide, kids under the age of 15, the numbers are even less. So it doesn't mean that there isn't pre-adolescent suicide that occurs. It's just that cases of completed suicide with very young children is not particularly common, and is oftentimes actually misidentified as accidents. So again, 12 cases per 100,000 for 15 to 19-year-olds, one per 100,000 for 10 to 14-year-olds. Adolescent suicide rate has doubled since the 70s, and for students under 10 years of age, it's very infrequent. The rate of attempts versus completion is about 50 to 1. You tend to see about 50 attempt suicides for every person who completes suicide. So when we look at suicidal ideations, about 20 to 25% of all teens think about suicide um, when we survey students. It's estimated that 2/3 of students between grades 8 and 12 will think seriously about suicide at some time. In 2001, there was a study that showed that 19% of U.S. students had seriously contemplated attempting suicide during the past 24 months. So, I mean, I think that's worth noting that although these feelings oftentimes are viewed as some aspects as being kind of developmental for adolescents, these are very serious numbers. We have a lot of students that are thinking and engaging in behaviors along the self-harm spectrum. And so, how can we best provide assistance to students that, again, are truly suffering? We have a great study that came out of the CDC in 2003 looking at youth risk for suicide, and they found that about 8.5% of high school students admit to having attempted suicide in the past 12 months. You see that with a lot of these different studies, both this one and the previous one that we talked about, you get different numbers, but part of that is that we're looking at different behaviors and they're different studies, and so it's important to look and see what the research says and understand that these aren't fused numbers, they aren't fixed numbers for any particular period of time, but it shows that these are certainly that suicidal behavior, particularly in adolescence, is a risk factor, and that we have to make sure that we're coming up with successful interventions and preventative strategies to assist students. When we look at suicidal correlates, we I think oftentimes people think that if people who are suicidal just get into a hospital placement, that somehow then those people will be safe and they'll be able to get appropriate interventions. And what we find is that although we certainly want people to receive inpatient treatment whenever they're at risk, just because someone's in the hospital doesn't mean that they're necessarily safe. So approximately 1,800 suicides per year occur in the United States in hospital placements, and we have parallel findings in Europe. In one study that looked at 76 patients who committed suicide, 49% had previous attempts, 25% were admitted for suicide, admitted to the hospital for suicide, and about 80% denied suicidal ideations at their last communications. And of those of those patients that committed suicide, 51% were on precautions or had a one-to-one observer, either sitting there watching them when they completed suicide, or were on 15-minute observations where a staff member has to put their eyes on that individual every 15 minutes as this person's on a suicide watch. So I think what we can take from this is that although we certainly want people in more restrictive settings to help them when they're at a very acute risk of suicide, that even very extraordinary measures that are being taken to help try to keep people safe um, sometimes isn't enough for when someone is really committed to injuring themselves. When we look at completed suicides, we know that 90% of completed adolescent suicides had diagnosable psychiatric disorders, primarily either mood disorders, substance abuse, or conduct disorders. So I think that makes sense that when we see people that have actually completed suicides, usually they would have met criteria for a mental health related issue at that time of, at the time of their suicide. So something that often gets overlooked when we talk about suicide and suicide prevention is that even though we collect data and try to find out what are some kind of common correlates and what are particular risk factors, it's important to remember that there's no real suicidal type, that suicide occurs across all age groups, classes, and cultures, and that although we do our best to try to um, help predict or help inform us as much as to students that are the most at risk. The truth is that this is a problem that affects everybody. That being said, there are some risk factors that we need to be very aware of when we're looking at students that are at the greatest risk for committing suicide. So the highest risk factors are people that are most likely to commit suicide are males between the ages of 14 and 24, substance users or abusers, folks with mood disorders, conduct disorders, or a high degree of impulsivity, Family factors. If you have a first-degree relative who has committed suicide, you have double the likelihood of risk for other immediate family members. We see that previous attempts are also a risk factor and increase the likelihood of a completed suicide. We also see that there's a contagion effect, and you may have heard about this in schools, that when there has been a suicide either at a school or one becomes um, or when one has occurred and everyone knows is aware of it, we see that the likelihood for a second suicide is higher. So, so it's something that schools have to be very mindful of, and most schools have or districts have a kind of crisis team that comes in after a suicide to help. Um, help students who are going through that difficult time, and also to keep an eye to try to provide assistance for other students that may be hurting, that this may increase the likelihood of a suicide attempt. We also know that access to firearms is a risk factor, and that folks that have access to firearms are at an increased risk of completed suicide. Folks that that are isolated or feel alienated at school. We know that it's less likely to have a confiding relationship with parents. 40% of suicide attempters ages 15 to 19 do not live with their parents. And so we see this when we talk about homelessness too, that when you think about 40% of folks that have attempted suicide aren't actually living at home, um, that's that's a pretty big indicator when when typically students are still at home in that at least 15 to 18 age group. And we see that with completed suicide that folks tend to have fewer peer relationships. As far as immediate risk factors, things that can occur in the environment that immediately put someone at risk for suicide when they may not have been particularly at risk before, involves disciplinary crisis. So we see in places of employment that when someone finds out that that their job's in jeopardy, that that there's some sort of disciplinary crisis, that can be an immediate risk factor for individuals. We also see this is true for morious crises. So when for a breakup or end of a relationship, that can be an increased risk for particular individuals for an immediate suicide risk factor. And then there are some other circumstances leading to guilt and shame. So some examples could be bullying, coming out of the closet for LGBT youth, low grades. All of those can be factors that precipitate suicide in populations or for students that may not have been a high risk before. So when we look at confidentiality in youth suicide, we have to remember that as teachers, there's any threat of self-harm supersedes the right to confidentiality. So we have to be careful when we're talking to students, and that we want to try to be as honest as possible, that when students say, I want to tell you something, but I don't want you to tell anybody, that's really a promise that we can't keep. We know that guardians have a right to be informed of the risk to their wards, and so we have to inform parents when when there's threat of self-harm. And so although oftentimes I think people really struggle with this, we have to understand that this is not an ethical dilemma for us in teacher education, that when we are concerned about a student harming themselves or others, we're obligated to report that and to try to make sure that students get help, and that there is no such thing as those confidential conversations among adolescents and teachers. Now, that being said, that doesn't mean, we want to instill a situation where students feel that they can come and talk to us. So it's all about how you present that information about, about that, even though you can't have confidential conversations, most people can frame that in such a way that still encourages students to have conversations and to talk to us, but doesn't make a promise that we can't keep. So when a student is released from the hospital, there are some steps that the hospital has to go through in working with the family to make sure that the environment that the student is being released to is a safe one. And some of those criteria are is that any sort of potential lethal means of self-harm have to be removed from the home. So this oftentimes, which is not intended to be a political discussion with parents oftentimes feels like a political discussion when we're talking about firearms, particularly if firearms were um, was um, a method that the student or the child was considered in their suicide plan. Um, Whatever the acute um, issues were as to the crisis have been discussed, and plans to resolve them has been arranged, usually with the therapist, the parent, and the child. The parents and family understand and agree with the follow-up plan, and therapists believe that the patient or family will follow through on the treatment recommendations. And the person must not be immediately suicidal or pose a risk to themselves or others, and they must not need medical attention. The patient and family also agree to contact services or go to the emergency room if there are worsenings, the situation worsens, and education of family regarding psychiatric illness, risk factors, and potential assistance also has to be provided. We know that intoxicated patients cannot be left alone, and this can sometimes be a problem, particularly when folks go into the emergency room. They're assessed for suicide, but they're inebriated or under the influence of drugs or alcohol. And so that becomes a real problem oftentimes for emergency rooms. And how do you, because you can't, it's, you just can't leave people that are under the influence alone in those situations. So the Family and Education Oregon study was, again, a lot of these studies that occurred at the kind of the late 90s, there was a time of quite a bit of federal funding around suicide research at that time. And so we see a lot of research that comes from that time. And so a lot of these studies, because a lot of these studies kind of come out at that time, we have to be aware that the reason for that is there was more federal funding for suicide and suicide prevention at that time. And we see that with federal funding structures and grant structures where certain topics will get more attention and more funding in a particular period of time, and then and then we won't see a lot of research for another 10, 15, 20 years, and then there'll be another increase. So some of it has to do with political powers as to who's in power oftentimes determines what gets funded and what doesn't get funded, and what are going to be the target areas for particular administrations for the Fed's research money. So anyway, the Oregon Education Study took a look at, again, some of these risk factors, and what they found was 90%, 96% of attempts occurred at home. 94.4% of homes had at least more than one suicide available at the time of attempt, and which makes sense because there's a lot of most homes there's a lot of possibilities in any home, and about 90% received education. Means of disposal compared to 23% who did not receive education. So we find that when families are actually educated, when students are released, that's very helpful to preventing future problems. Final takeaways from this, from this lesson, and I please know I acknowledge that this is a very difficult conversation. And a difficult topic for many of us to talk about, as the number of people who have had their lives touched by suicide is very high. But it is also important for us as teachers to be aware, even though it may be difficult, so that we can be helpful to our students and to be knowledgeable, even though these topics are very difficult and hard for us to talk about. So some final thoughts. It's important to know that the word suicide doesn't plant an idea of suicide or other. So again, the use of the word suicide isn't a problem. And oftentimes for students it can be a relief that someone is actually talking about it and using that term. But it's important for you also to know your school's policy and know how, when you need to report, how you report, and what the school, how the school can support you as a teacher in these situations. And then finally, don't be afraid to ask the question, and don't be afraid to get some backup from other professionals in the school. So these aren't decisions that you should really be making on your own. These should be ones that you're getting assistance from others to better help the students. So thank you very much for making it to the end of this. And it's really important for us to be aware of these issues and to be knowledgeable, because we suicide is going to touch all of us when we work in schools, particularly in middle school and high school, if we work in the field for very long. So it's important to have knowledge so that we can be best prepared for when we deal with these situations.